The next session is Special Lecture 4. The chair is Dr. Tetsuo Takehara. Dr. Takehara, please.
Good afternoon, member and colleagues. I'm Tetsuo Takehara, and I will chair this session from Osaka today. It's great pleasure and also honor for me to chair this session talked by Professor Masatoshi Kudo. He is professor and chair, Department of Gastroenterology and Hepatology, Kindai University, Faculty of Medicine, Osaka, Japan. I don't think we need any further introduction for him because he is very famous and well known for the audience. So let's start a special lecture. Professor Kudo, please start your lecture, please.
Thank you very much, Professor Takehara, for kind introduction. And I'd like to thank Professor Ueno for giving me this opportunity. So my topic today is that all stage of ACC patients benefit from systemic therapy combined with local regional therapy. This is my disclosure. As you know, in Japan, the first-line agent approved 8 regimens are approved, and 3 regimens are approved for second-line agent. And among them, 2 regimens are combination immunotherapy, and 1 regimen is ICI monotherapy. And this is a 5-year survival rate and median OS in Japan. The 5-year survival improved from 5% to 58%, and median OS improved 4 months to 18 months during the 30 years. Probably because of a nationwide surveillance and several development. But most recent registered patients benefit from these systemic agents. So message of my talk will be all stages of ACC patients benefit from systemic therapy combined with local regional therapy, including resection. Patients with objective response live long, so the regimen with higher objective response rate and lower PD rate provide better survival. So early stage ACC, the recurrence after RFA by Dr. Shina, local recurrence is very low, but 5-year recurrence rate is 80%. This is similar to the surgery recurrence rate, and also OS is similar RFA between RFA and surgery. So overall survival of ACC after resection, after 5 years, the survival rate continues to decline after 5 years, different from other solid tumors. This is because high recurrence rate after curative therapy and also treatment for recurrence deteriorates the liver function. And the suppression of recurrence has been a strong unmet need in the world. So several trials were conducted, STORM trial or vitamin K or retinoid or so on, but all trials ended with negative results. So now we have the positive in BRAVE 050 and the intermediate stage. Of course, there are many phase 3 trials are ongoing, but a small phase 2 trial or proof of concept study was conducted in advanced stage. So all of the stage benefit from systemic therapy and with or without local regional therapy or resection. So I'd like to show you the BRAVE 050 and the NIVOLVE trial. This is, as you know, this data was presented at ASCL this year and published this week in Lancet. And this study, the patients who received curative resection ablation randomized to atezolizumab or active surveillance. Primary endpoint was recurrence-free survival, and with the median for a period of 17.4 months, the median RS, both atezolizumab active surveillance, not evaluable, but hazard ratio was 0.72, p-value 0.012, and 1-year recurrence rate is significantly better in atezolizumab, 78% active surveillance, 65% atezolizumab. So at least the early recurrence is inhibited by atezolizumab. This is the first trial who met the improving recurrence-free survival. This is a phase 2 NIVOLVE trial, nivolumab single agent trial, single arm trial, and we a total of 55 patients who received ablation or resection. These patients are resected patients, and these patients are recurrent, had a recurrence after 1 year nivolumab. When we look at the recurrence case, if there is a CD8 positive T cell is abundant in the tumor, recurrence is few, but the Treg positive in the tumor, there is a very frequently recurrence is found, and also beta-catenin pathway is activated. The recurrence is very frequent. But this is speculated that regulatory T cell or beta-catenin activation is suppressed by bevacizumab. So maybe ICI monotherapy has a limitation, but the atezolizumab could improve the recurrence-free survival. And also, patient-reported outcome was presented at ASCO this year over this 050 trial. And this patient-reported outcome clearly shows health-related outcome, QOL. The active atezolizumab does not worsen. So adjuvant atezolizumab does not impair health-related QOL and the role function, physical role or emotional social functionings, because these are the cancer-free patients after resection ablations. So this is very important of data. So I'd like to move on intermediate stage. The treatment goal of advanced stage ACC is the improvement of OS by preserving liver function and the sequential therapy with effective drugs. However, intermediate stage without vascular invasion or extrahepatic spread. Pathological CR by obtaining necrosis shrinkage with combination of systemic and local therapy is a treatment goal. So there are several trials were conducted. First, tactics trial, sorafenib TACE versus TACE. Tactics trial clearly shows met its primary endpoint of PFS prolongation. The hazard ratio 0.6 and p-value was positive 0.02, but not OS. But the clinically meaningful OS prolongation was observed. 5.4 months prolongation was observed. And also, multi-center proof of concept study was conducted. This is a proof of concept study in up to 7-out intermediate stage ACC. This study showed the upfront lenvatinib showed better PFS, ORR, and the preservation of liver function, and OS than TACE alone. This proof of concept study triggered the importance of upfront lenvatinib in TACE unsuitable HCC patients because abnormal tumor vasculature is normalized by anti-VEGF agent, and the microvessel density, tumor interstitial pressure, vascular permeability is normalized, and drug delivery is improved, and resulting in improving TACE efficacy. So if TACE is performed first for multifocal disease, but only palliative TACE is possible, and efficacy is not good. Liver function is deteriorated, and hypoxia-inducible cytokine is increased, resulting in recurrence or a new lesion. However, lenvatinib is introduced first. Lenvatinib induces anti-tumor effect, normalized tumor vessel, improved drug delivery, resulting in improving efficacy of TACE, and also only super-selective TACE is possible. Lenvatinib inhibits hypoxia-inducible cytokine, then preserving liver function, then and efficacy of TACE is maximized and liver function is preserved. Then recurrence, new lesion will be suppressed. And then tactics L, Len-TACE sequential therapy was performed. These are treatment strategy of TACE unsuitable intermediate stage ACC. Len-TACE sequential therapy, tactics L study is a single arm study, a phase 2 prospective multi-center single arm study, but a similar design was adopted with tactics trial. The difference is instead of sorafenib, lenvatinib was used, and not randomized study, but single arm study. But the primary endpoint is same. The tumor response is very high. Best response, complete response is 68%. And duration of response was more than 12 months in more than 50% of patients, which is very good. And regardless of up to 7 out or in, the complete response rate is more than 50%. And also macroscopic pathological type. Usually the simple nodular type is very good candidate for TACE, but other confluent multinodular type or simple nodular type with extranodular growth or infiltrative type is resistant to TACE. But Len-TACE clearly show the ORR is similar to simple nodular type, and the CR rate is also similar to the simple nodular type. So Len-TACE achieves complete response even in TACE-resistant macroscopic pathological type ACC. We compared the Len-TACE from tactics L trial and the TACE from tactics. So IPW was used for matching the baseline characteristic of 2 prospective trials. Up to 7 inpatient PFS hazard ratio 0.7 and up to 7 outpatient hazard ratio 0.49, which means the up to 7 criteria outpatients show better synergistic effect by combination therapy of Len-TACE. In other words, up to 7 out is a TACE unsuitable patient population. So systemic and TACE combination strategy should be introduced in up to 7 outpatient. Also, in terms of OS, similar trend was observed. Hazard ratio was 0.89 in up to 7 inpatient, and the hazard ratio 0.41 for up to 7 outpatient. So, up to 7 criteria outpatients showed better synergistic effect by combination therapy of Len plus TACE. So, treatment strategy of intermediate stage ACC in era of combination immunotherapy still TACE suitable patient up to 7 in or simple nodular type. Len-TACE is a choice of treatment because achieving CR by upfront lenvatinib, achieving high quality CR. So also TACE unsuitable patient up to 7 out non-simple nodular type. Len-TACE may be indicated in patients who achieve CR by TACE. So intermediate stage ACC, always we consider TACE and lenvatinib is a set of treatment, TACE unsuitable patient. Main player is lenvatinib, but the key player is TACE. Lenvatinib alone or TACE alone cannot achieve high quality CR, but CR cannot be achieved by lenvatinib alone. TACE suitable patient. Main player is TACE, but lenvatinib is a key player. Sustained CR or high quality CR cannot be achieved, TACE alone. But if you look at the atezobev in BRAVE 150, EBCLC-B stage, very good response can be achieved, can be observed, 50% response rate, including 70% CR rate, 4% PD. So the replacement study was performed at Atezolizumab for up to 7 outpatient. This is a prospective trial to test if the same efficacies can be achieved in up to 7 outpatients in Japan. This was presented at ASCO and ILCAT, and Dr. Richard Finn came to me, and this data is what he wants, and very good. And this multi-center single-arm phase 2 study, intermediate stage beyond up to 7 criteria, no prior taste, Child-Pugh A patient were treated by Atezolizumab in 74 patients in 34 sites. And the exploratory analysis was performed. PFS was compared between Atezolizumab and TACE historical data in the same institute after baseline is matched by propensity score matching and IPW. And the baseline characteristic is older, 74, and hypertension, diabetes is comorbidity was found 81%, 42%, and BCSC stage B up to 11 criteria, outpatient 34%. PFS was 9.5 months, which is good, and trial met its primary endpoint by achieving more than 55% of lower boundary of 90% CI. So this trial was positive, and subgroup analysis show there is no difference between viral or non-viral etiology or number of liver tumors more than 11 or less than 11. Usually TACE more than 11, the efficacy is not so good. And Atezolizumab show a better PFS than TACE after propensity score matching or IPW, hazard ratio 0.59 and 5.54. And response rate is also good, 44.6%, including 17.6% CR, and the PD rate is very low. This is very similar to the sub-analysis of INBRAVE 150. And the waterfall plots clearly show even though there is a comorbidity, such as diabetes, hypertension, both, the deep response was observed on the Child-Pugh 6, even, and also AFP greater than 400 or up to 11 out, the deep response is observed. And the durable response, spider plot show a durable response. And also, multi-center proof of concept study was performed, curative conversion, proof of concept study, 7 multi-center study. So these, in these centers, TACE unsuitable intermediate stage, Child-Pugh A, patients were enrolled as a first-line Atezolizumab, and in order to exclude selection bias, consecutive case was collected. In a total of 110 patients received curative conversion. Then the achieved complete response or cancer-free rate is 35% by resection, 7 ablation, 13 TACE or TACE 15, and Atezolizumab only. And among them, 23%, 25 cases achieved drug-free status. And the progression-free survival is much different. Patients with curative conversion show a better PFS than standard of care of Atezolizumab. And the patients with curative conversion OS is better OS than standard of care of Atezolizumab. So intentional curative conversion achieves clinical CR and or drug-free status during Atezolizumab treatment. But when we look at the Atezolizumab followed by curative conversion data, this is a replacement study. As I said, I said the durable response was observed, but in partial responder case, if you look at it carefully, these patients sooner or later becomes PD. So we have to do something for PL cases in order to achieve complete response. So when tumor shrinkage stops like this or during still effective, if it is operable, ablatable, tasteable, we should perform resection RFA curative taste to achieve complete response or cancer-free. So actually, 40 patients achieved response, objective response per RECIST 1.1. And this is not the clinical study, so only 25 patients from 38 PL patients received curative conversion, and all of them achieved clinical PR. So, like this case, up to 7 out and confluent martinolial type ACC, atezolizumab followed by combination of TACE and continue atezolizumab. The tumor shrinkage was observed, so hepatic segmentectomy was achieved and cancer-free, drug-free was achieved. So all 3 nodules are complete necrosis and also pathologically CR. This is a Dr. Kudo's case, so large two tumors, and the response was good, the PR was achieved, but and then selective TACE was performed, but still there might be a viable tumor, so microwave ablation was achieved, then performed, then drug-free status was achieved. So atezolizumab curative conversion therapy, the usually intermediate stage CC is a technically TACE possible, but oncologically TACE unsuitable patient. So, and the selective TACE, sometimes difficult or selective TACE or difficult, impossible, like up to 11 out of viral multiple tumors, curative conversion possibility is low. So these might be a systemic therapy suitable, but at least these patients, the curative conversion should be a curable disease. The curative conversion should be performed. So atezolizumab curative conversion, the ABC TACE sandwich therapy gradually became global standard. The ESMO this year, this week, the Dr. Vogel gave an educational lecture, and he introduced new avenues, proof of concept study, curative conversion. This is not a one-way systemic. In the past, local region therapy or surgery and then systemic therapy. But the systemic therapy first, local region therapy, it can be change the curative conversion, and cited the paper, and as Professor Kudo is, and his state, Professor Kudo is proposing, it is important to combine all of treatment strategy we currently have, which is systemic therapy plus local region therapy or resection to achieve clinical pathological CR. So this is another point, another meeting. ILCA conducted in maybe September, early September, tumor board case. The French case, the presenter show 6 centimeter infiltrative type BP2AFP greater than 12,000 nanogram RB1, and tumor board discuss, and all of them recommend atezolizumab. So 3 cycle of atezolizumab was achieved partial response, and shrunk to 4 centimeter, BP2 still there, and AFP dropped to 6.8. And what's next? What should we do? The panel, including IVR and surgeon, Pinato oncologist, and hepatologist, and Richard Finn, and Amit Singhal, hepatologist. The Richard Finn state curative conversion with local region therapy proposed by Dr. Kudo may be the choice of treatment at this timing for this patient, since drug-free status is very important for patients. And actually this patient received local region therapy, radioembolization. And radioembolization was performed after 3 cycles of atezolizumab, and the partial response was obtained. and no distant metastasis, and also VP2 disappeared. And what's next? What should we do? Then the ABC tear sandwich therapy was performed by continue atazobeb, and the complete response was obtained per RECIST 1.1. What's next? Many discussions. Continue atazobeb or drug off, but there is no criteria or transplantation. This patient start atazobeb and radioembolization and continue atazobeb. So this ABC tear sandwich therapy achieved RECIST CR, and they performed transplant. But the pathology show radioembolization scar without malignant cells, and 7 months after transplant, no tumor recurrence on imaging. So ABC conversion gradually became a standard care in the other outside Japan, but drug-off criteria has not been established outside Japan, they said. And actually in Japan, drug-off criteria is established clinical complete response after combination immunotherapy combined with local regional therapy. Drug-free criteria, drug-off criteria after ABC conversion is the imaging, CL, and the normalized 3 tumor markers more than 24 weeks, and no intratumoral arterial flow by CUS. In our proof of concept study, consider drug off when all of these three criteria is fulfilled, and all of them are not, recurrence is not found. Of course, this criteria should be validated further. And in case of stable disease, as you can see, sooner or later it becomes PD, so we should perform inserting immune boostase, mass reduction, and activate the cancer immunity cycle by releasing cancer antigen. So when interruption due to AE or stable disease or slow PD at 4 cycles, we should perform TACE and achieve partial response or complete response. This is such cases like SD or slow PD after 6 cycles of atezolizumab, and proteinuria appears. So we performed CTACE in order to achieve mass reduction and cancer antigen release, and continue atezolizumab. As you can see, this is because of anti-VEGF effect, the TACE has achieved complete response, and atezolizumab, subsequent atezolizumab achieved pathological CR, so cancer-free drug-free status was achieved. The many paper show the immune modulation effect in local regional therapy. Local regional therapy release cancer antigen and increase effector immune response cells, CD4, CD8 positive T cell, or inhibit the immune suppressor cells like MDSC Tregs. And the CD8 flow into the SCC and attack the tumor, and the PD-L1 is upregulated, and the PD-L1 antibody can achieve complete response. So there is a synergistic effect of IO and TACE, cancer antigen release by TACE, and this further increased activated CD4 T cell or activated CD8 T cells in the blood. And also pre-TACE biopsy or post-TACE surgical resection, PD-L1 is upregulated in the tumor cells. So in the same paper, the not ablated or TACE tumor, the CD8 positive T cell has increased, especially in responders. And those nodules, CD8 rich tumors, show a partial response. So, and also synergistic effect of BEV and TACE, VEGF is produced by TACE, but bevacizumab inhibits hypoxia-inducible VEGF production, as you can see here. So there is a good synergistic effect. Actually, in our case, 50 patients was SD per RECIST 1.1 on atezolizumab, but 12 patients received, only 12 patients received, 12 out of 50 patients that received curative conversion, and 10 patients achieved clinical CR. So The important thing is even SD or slow PD patient, CR can be achieved by TACE, even in this SD or slow PD patients. Now, IMPACT trial is ongoing in Japan, phase 3 trial, induction atezolizumab, and SD patients are randomized 1-to-1 to TACE plus atezolizumab or atezolizumab. So this evidence is very important. So I'd like to move on to advanced stage ACC. Advanced stage ACC, in era of sorafenib, this is a prolonged OS by stable disease, in other words, era of disease control, or next era, lenvatinib atezolizumab. This has a high response rate, so prolonged OS by high objective response rate. And the third era is a cancer-free by combining systemic and local region therapy. So from disease stabilization to cure, in the past, the OS correlate with post-progression survival in only sorafenib era, but the OS is prolonged by higher ORR, lower PD rate, and longer PFS. Surrogate marker of OS in individual patients is important. It's not clear which patient live long after initiation of systemic treatment. It is essential to know the surrogate marker for longer survival. This is not easy. EASL HCC clinical practice guideline published in Journal Hepatology 2018, objective response in local regional therapy. A recent meta-analysis indicated 7 clinical trials assessing survival outcome after local regional treatment. And of course, each individual study show better survival for responders than non-responders. But the meta-analysis clearly showed the hazard ratio 0.39. So for phase 2 trials, the panel and dose complete response as a primary endpoint. However, objective response in systemic therapy, objective response by embraces, has been shown to correlate with OS in only 2 clinical trials. So additional data is needed to endorse this approach. This is a complicated or very long-lasting discussion or debate in field of systemic therapy, mainly cytotoxic agent, analysis of survival by tumor response. Many statisticians said the usual method of comparing responder and non-responder is biased in favor of responders, and these results are frequently misinterpreted. So two valid methods are proposed by these statisticians. These are the landmark analysis and multi-bias test. And another paper, challenges of guaranteed time bias. Usually guaranteed time bias, known as immortal time bias, is disease response. This is a factor of after treatment initiation. So also they introduce statistical method like landmark analysis or Cox regression analysis with objective response as time-dependent covariate. And Simon and Makchi also propose new method. And in REFLECT trial sub-analysis, we presented at ASCO GI an oral session and submitted to Journal Hepatology, but it took 3 years and with a 4 major revision, but never rejected and finally accepted. But clinical question is objective response associated with OS in case of ACC? The answer is objective response is an independent predictor of OS in individual ACC patient. Responders show better survival. This was confirmed by landmark analysis, multivariate analysis, Simon Makchi and multi-bias test. Landmark analysis also, at this point, the responder live long. And also, each lenvatinib sorafenib show a better survival by using multi-bias test and the Cox regression multivariate analysis with objective response as a time-dependent covariate. Objective response is the most strongest predictor, hazard ratio 0.55. It is better than, stronger than AFP or macrovascular invasion. And finally, the in 2018's clinical practice guideline of EASL, only two papers were included, but additional 3 papers correctly analyzed statistical analysis was performed. So data is robust. Evidence was established that objective response is an independent predictive marker of OS in individual patient level. So meta-analysis, which is the highest evidence level, clearly showed objective response predict OS in individual patient. It also suggests that the regimen with higher ORR is a better regimen. So if the response is obtained and the second line, third line, sixth line, fourth line regimen's effect is same, OS should be prolonged in individual level. And we look at the 2 combination immunotherapy. The first ICI conducted in first line agent compared to sorafenib has an OS hazard ratio as 0.85, PFS hazard ratio 0.93. Response rate was 15%, PD rate was about 40%, and systemic steroid was 11%. This is a single agent ICI's very typical data, but the tail plateau as observed, and Kaplan-Meier curves cannot separate for, in other words, about 6 months. In other words, early death cannot be protected, cannot be avoided. So early progression is not protected. And the next started trial was the IMBRAVE Himalaya study started earlier than IMBRAVE. So hazard ratio, OS hazard ratio 0.78, hazard PFS hazard ratio 0.9. Response rate is 5% improved, but PD rate is similar to the single IO therapy, and the high dose steroid is 20% because of tremelimumab, and the long tail plateau was observed, but Kaplan-Meier curves do not separate from about 6 months, and no significant difference in PFS. But in atezolizumab, OS hazard ratio improved 0.66 and PFS hazard ratio 0.61. And the response rate is doubled as compared with single agent ICI, or PD rate is half as compared with ICI monotherapy. Systemic steroid is similar to ICI monotherapy. Tail plateau is observed, but not long-term survival is observed. But the Kaplan-Meier curve separates, but very quickly, and PFS is significant. So this is my speculation, but the IO monotherapy is only effective in active immune class. Immune class is very important, inflamed and non-inflamed class. As part of active immune, ICI monotherapy, response is obtained. But IO combination, this combination maximizes the active immune class. And IO plus anti-VEGF expand the suppressive microenvironment, and the benefit from IO monotherapy, IO may be a little bit more. These are the 40% PD. And the benefit from IO plus anti-VEGF is even beta-catenin mutated HCC can benefit from IO plus anti-VEGF. So wide benefit risk toxicity is a very, very important concept to select the first-line systemic agent as ASLD guideline. If there are no contraindication of atezolizumab is the first line, and if yes, steroid regimen can be selected. And this is also Richard Finn's data. Also, atezolizumab is selected if contraindication to beva is not indicated, and if there is contraindicated to beva, durvalumab will be selected. And in Japan also, combination anti-VEGF suitable patient atezolizumab is selected in routine clinical setting, and anti-VEGF unsuitable durvalumab is selected. And combination IO unsuitable patients, lenvatinib or durvalumab is selected, and CHEP2B7-8 or elderly patient durvalumab is selected. And the Himalaya trial, as you know, the pharmacodynamic biomarker T300 plus D steroid regimen drives an acute expansion of CD8 positive lymphocyte that is associated with response. This is also a good response. And this is a change of CD4 T cell counts by 4 regimens. Of course, the steroid regimen is most important in CD4 T cell in the blood, but it shows single peak of CD4 positive T cell counts at 15 days from the initiation of steroid regimen, and also similarly single peak of CD8 positive T cell counts at 15 days from the initiation of steroid regimen. So the IMA's peak shows a single peak at around 1 month from the initiation of steroid regimen. So only at the beginning of anti-CTLA-4, abundant CD4, CD8 positive T cells are released in the bloodstream. Only at the beginning, objective response to steroid regimen is achieved. No late responders, but this response is sometimes very high quality. At this time, IRA also occurs right after the first initiation of anti-CTLA-4. As you can see, this one, the early stage, if the responders, the very early step, all tumor marker drops and all metastasis disappeared. Clinical CR is no late responder, but the drastic CR is obtained by this regimen. This is only one single steroid, but achieve complete response in early stage. So, and also IMAEs. And our data show long-term survivors more than 4 years among 6 patients, non-responders in 2 cases, but 4 cases are responders and also achieved clinical CR with drug-free status. So this is a 4-year update about survival for steroid regimen, 30.7%. The at-risk patient is enough 103. So among this long-term survivor, response does more than 50%. So especially, probably I assume 50% and resist PR patient, among resist PR patients, resist CR patients is increased with drug-free. So if once response is obtained, the depth of response is very good. So steroid regimen is currently the only one regimen that maximizes the efficacy of immunotherapy very quickly, only early stage, in early timing. Only in active immune class, resulting in CR or super response by systemic therapy alone. But sometimes, if it's not effective, the hyperprogressive disease is observed. So steroid regimen is currently the only one regimen that achieves super response by systemic therapy alone very quickly, even in advanced ACC. However, there is a trade-off between super response and many IMAE. Thus, it's not recommended as a first-line option in the era of multi-effective combination immunotherapy, but should be used at least one time in the sequential systemic therapy for advanced ACC. It is important to switch to other agents or local immunotherapy as soon as possible if it is not effective before 3 weeks. So treatment strategy in obesity in era of combination immunotherapy, treatment strategy should be based on correct understanding of the immune microenvironment or immune subclass ACC and mode of action of each immunotherapy regimens. Launch study clearly showed, even in advanced stage ACC, show a survival benefit, and also LEOPARD study clearly show. This is a lenvatinib plus hike study, very high CR rate and response rate. And the model phase study, skip co-inhibition of TIGIT and PD-1, PD-L1. This is very important. And the model phase study clearly showed atezolizumab plus anti-TIGIT achieved high response, 43%, and modified RECIST 55%. And this triple regimen show better PFS than IMbrave 150 or atezolizumab. And no increase of adverse event or severe treatment-related severe adverse event. So currently, this study is ongoing, triple regimen versus atezolizumab. So now a new paradigm treatment strategy. Intermediate stage, at the early stage, maybe once it's approved, atezolizumab play an important role. Intermediate stage, Lentase or atezolizumab conversion, or even advanced stage, Lentase or atezolizumab TACE. So this is my final slide. Sequence combination harmonization, molecular therapy, and systemic therapy has become important all stage of HCC in the world. In the world, responders to systemic therapy for HCC have long-term survival. Therefore, it's important to select a regimen with a high response rate and a low PD rate, and to increase the response rate with local regional therapy. Many trials are ongoing, IMPACT and IMbrave 150. So treatment paradigm of HCC is further drastically changing. Thank you very much for your attention. I'm sorry.
Thank you very much, Professor Kudo. Your talk is very excellent and comprehensive about the new paradigm of HCC treatment and in futures. So this is a special lecture, and we do not have time to take questions from the audience. But I think today's lecture strongly suggested to us the combination of systemic therapy and local regional therapy can improve patient outcome with all HCC stages. Thank you very much, Professor Kudo.
Thank you very much.
Thank you very much, Chair and Lecturer.